Thanks so much, Janice. I think that was a really great overview of melanoma and its many complexities and all of the challenges that we face in evaluating our patients and how dynamic it is as they go through treatments and they respond and they don't respond, and each turn in the way, each turn in the road presents new questions and possibilities to improve the way we treat patients. So I think it's a very interesting field. It's a very exciting time to be in cancer. But of course, every day when we're in the clinic and we have to deliver bad news, we are reminded that we have only more work yet to do. So I'm going to give a little overview specifically about immunotherapies this evening. And I'm going to introduce you to the cancer immunity cycle and talk about some advantages of immunotherapies in particular. And I wanted to highlight oncolytic viruses because that's something that we do a lot of here at Rutgers, and also talk about some future directions for our field. So the immune system can induce regression in some human cancers. And we call this spontaneous regression, and this phenomenon has been observed for years and years and years. And what I mean by that is there are case reports of some patients with advanced cancer who are able to survive despite their cancer, and sometimes the cancers even disappear. And this is most often reported with melanoma and has also been reported with patients who have lymphoma, like follicular lymphomas and indolent lymphomas. And just the idea that sometimes the body can take care of the cancer on its own, I think is fascinating and is really the building block of this field. So everything that we're doing with cancer therapy is really just trying to take what the body already knows how to do and try to help it along. So you can see a picture here. This is a melanoma, and in the middle of the melanoma, sorry, no pointer. In the middle of the melanoma, you see that it's starting to sort of disappear. That black spot has sort of normal skin in the middle of it, and if you look under a microscope, you can see lymphocytes inside the tumor attacking the tumor. And of all of our immune cells, we think that the most important ones for eradicating cancer are the lymphocytes. And lymphocytes are made up of T cells and B cells. And the T cells are the ones that we think are the workhorses. So most of immunotherapy for cancer is focused on T cells. However, I think the field is starting to recognize the important contributions of the other types of immune cells as well. So the cancer immunity cycle is depicted here in this cartoon, and this is something that all of us in this field sort of look at once a week, where we see a paper or we have a reference to this figure, but I'll walk you through it. The idea is, if you start down at number 1, that you have your normal cells, and one day, for whatever reason, one of the cells decides to accumulate some mutations, and over time it turns into a cancerous cell. And so the first step in this cycle is that the antigens, which are the little pieces of the cancer cell, are released, and they are sometimes recognized by the immune system. And the cells that sort of do that recognition are called antigen presenting cells or dendritic cells. And so in number 2, you see the immune system start to kind of smell the cancer and get its first whiff. And then many steps have to happen in order for the body to fight back a little bit. And so the next step is that the antigen presenting cells must go and find a T cell inside your lymph nodes. And we all hear about lymph nodes in terms of surgery and staging. And the lymph nodes are really the part of the body that drains the tissues, and that's sort of where sometimes I say that's where the garbage gets collected in the lymph nodes. All the extra fluid and extra cancer cells and dead cells and pieces of infection, it all gets a chance to mingle in the lymph nodes. And so after the antigen presenting cells and the T cells meet each other in the lymph nodes, certain T cells who recognize certain antigens are selected to go forth and carry on, and they get growth signals. Mainly interleukin-2 is a growth signal that is naturally made in your body and causes T cells to proliferate and grow. And then they get put back into the bloodstream because the lymph glands always dump back into the bloodstream just before the bloodstream enters the heart. And then those cancer-specific T cells have to find their way back to the tumor through the body, through the blood vessels, and into the tumor microenvironment. And then they have to re-engage with the smell that they first smelled. They have to re-engage with the cancer antigen. And then once that's where the magic is. And once that magic happens, the killer, the cytotoxic T cells can actually release chemical signals that kill the cancer cells. And this probably is happening to all of us in this room every day, that we have pre-malignant cells, we have funny cells, we have damaged cells, and our bodies can do this naturally, where we recognize that something's not right and our immune system responds to it and takes care of it. And we all are probably doing this every day, and that's called equilibrium, where our immune system is able to fight back. And only when there's a failure of this cycle does a tumor grow. And only when a tumor grows to a certain size or starts to cause symptoms or starts to look funny on your skin is when, you know, medicine actually kind of recognizes it as a cancer. And immunotherapy has a long history, dating back first to the 1890s, where bacterial toxins were given to patients in an effort to save them, and there's been a lot of ebbs and flows. But there was really, in the 1990s, the James Allison discovered the CTLA-4 molecule, and he became a champion to develop ipilimumab, which eventually became ipilimumab, the first checkpoint inhibitor for cancer, and that became part of early phase clinical trials in the early 2000s, and that's when I got interested in the field, because my first job out of college, I was a data coordinator at the Dana-Farber Cancer Institute, and I happened to be the one writing down all the data for the patients who were on that first in human phase 1 clinical trial of that immune checkpoint. And I really fell in love with the idea that, hey, we do this every day naturally, just let's try to fight cancer by boosting that idea. So that's my personal story of how I got interested in this field. Now this timeline is now, this one is not up to date, but it's starting to get really heavy at the right end of the field. As Dr. Maynard said, we have many 8 or 9 drugs approved in the last several years for melanoma, many of them immunotherapies. So Dr. Maynard talked a little bit about the anti-CTLA-4 and anti-PD-1 antibodies. I like the way where she says that the immune system can kind of fall asleep at the wheel a little bit. And that's what happens. And on a molecular level, the tumor cell can put up certain proteins called PD-L1, which can kind of tell the immune system to go away, take a nap, fall asleep at the wheel. And because they're negative signals, the immune system gets dialed down a little bit, and the cancers are able to grow unchecked. And combinations of using more than one immune checkpoint inhibitor have been demonstrated to be successful therapy in metastatic melanoma. And so if one drug can help a fraction of the people, many clinical trials are looking at the idea of, let's add more than one drug and try to raise the bar a little bit across the way. And so over time, we have seen our therapies improve from chemotherapy to targeted therapy to first and second generation immunotherapies. And the goal of the entire field is to really try to get more of patients to respond to their first-line therapy, get a durable response, have minimal side effects, and a good quality of life. So I'll spend a minute talking about one of the earliest immune therapies, which is a cytokine called IL-2 or interleukin-2. I already mentioned that IL-2 is what your body naturally makes to turn your T cells on and make them grow, grow and proliferate and differentiate and be specific to cancer once they've been activated. And this has been turned into a drug which is given to patients and FDA approved for patients with metastatic melanoma as well as metastatic kidney cancer or renal cell carcinoma. And so IL-2 is used in select centers for select patients because it does have a lot of side effects that come on in the short term and are usually quickly reversible. But IL-2 is sort of the first immunotherapy that demonstrated that although the majority of patients unfortunately do not respond, the ones who do respond are able to have a durable control of their cancer, and it's a long-lasting type of response because we believe once the immune system is activated and knows what the cancer looks like, it's kind of like having, the measles. It's the same idea that once you've had it, you're exposed to it, and your immune system has a memory. So I've mentioned some of the advantages of immunotherapy. One advantage that I'd like to highlight, and maybe the reason for some of the durable response, is that once you have T cells that are recognizing your tumor and in your tumor, if your tumor tries to mutate or change or develop resistance, the whole process could potentially start back over. And so that's called epitope spreading, where maybe protein A was recognized when you first started on your therapy, but over time you get to have proteins B and C recognized as well. And so then you have this multifaceted, multi-pronged immune response that maybe is a little bit harder for the cancers to develop resistance to. So, and that is related to the durability. And then a third key advantage of immunotherapy that I'd just like to highlight is the ability of T cells to enter the brain. And so people always talk about brain metastasis and melanoma because it's one of our most feared complications. We are always asking patients to have a staging MRI to check because melanoma cells have this propensity to spread to the brain. And in general, melanoma, even though it's not a very common cancer in the broad scheme of cancer, lung cancer, breast cancer, and colon cancer, prostate cancer, they're all much more common cancers, but 50 to 65% of patients with melanoma who die of melanoma will have brain metastases at some point. And when we think about using medical therapies to help patients with melanoma brain metastases, everybody talks about the blood-brain barrier. And the blood-brain barrier is really the lining of the blood vessels that is what keeps the blood inside and the brain outside, and it's sort of less porous than other blood vessels. And so many traditional drugs are not able to go into the brain at all, or they're at a small fraction of the level in the brain is really just a small fraction of what the level in the blood is. So it's a difficult way to deliver, it's a difficult place to deliver traditional drugs. But immunotherapy, we don't exactly need the drug itself to go there. We need the T cells to go there. And fortunately, the T cells can enter the brain when they need to. So this is an interesting study of immune infiltrate or in brain metastases, meaning T cells inside brain metastases. This is about 100 patients who had their brain metastases removed by surgery, and then the tissue was examined under the microscope to look for T cells and other lymphocytes. And in this study, they showed that patients who had a high immune infiltrate live longer than patients who had a low immune infiltrate, which just suggests that it's a better prognosis to some degree, although always a very serious thing to have melanoma brain metastases. So that just suggests that even in the brain, the immune system is playing a role. And this is a case study I'd like to share with you that demonstrates a couple interesting features. This is a patient who developed, had no symptoms, but had a brain MRI in order to try to go on a clinical trial, and was found to have 7 or 8 brain metastases. And the largest one is here, which you can see as the spot on the MRI, which enlarged very quickly as he was preparing to have treatment. So he had treatment of focused radiation therapy, which is called gamma knife radiosurgery, to all 7 of his metastases, all 5 of his metastases, and then was initiated on second-line therapy with pembrolizumab. He had ipilimumab in the adjuvant setting. So this patient had an interesting course because he had a good deal of swelling of this brain metastases, of the largest one, and the other brain metastases all disappeared. And so this phenomenon of swelling followed by response is something that we call flare or pseudoprogression. And this is something that's a well-recognized phenomenon in the body, that sometimes on the CAT scans the tumors look bigger at first because they're sort of swollen up with the healthy immune cells, but they look like they're growing on the CAT scan. And then if you continue therapy, they actually start to shrink down later. And so this patient had this phenomenon occur in the brain, and on continued treatment over many months, that spot slowly resolved. And so I think that the brain parallels the body in that the cells are important, they impact prognosis, and the same patterns of response can occur in the brain, that sometimes tumors just completely shrink, and sometimes they get bigger, and sometimes, unfortunately, there is no response to therapy. But I think that we see everything in the brain, everything that we see in the body, we see in the brain as well. And so I'll be very excited to hear about a new clinical trial that's being reported at this year's annual meeting of the American Society for Clinical Oncology, where they have taken patients who have melanoma brain metastases, and instead of giving them the usual treatment where they get surgery and radiation immediately upon diagnosis, they've given them the immune checkpoint antibodies, ipilimumab and nivolumab, and have done a clinical trial, and they're going to report their results in terms of the safety and the efficacy on Sunday, June 4th. And so I know I'll be in the audience in Chicago. Dr. Maynard will be as well. And I think that's sort of a next frontier that I'm excited to see, that we're doing clinical trials in and getting results. So next I'll spend a few minutes talking about oncolytic viruses. This is really sort of a niche field, but I think it's an up-and-comer because the viruses have the ability to activate the immune system. After all, our immune systems have evolved in coevolution with viruses, and it's that's sort of its job to recognize viruses and respond to them. And so we're using them as cancer therapies. So viruses can be in their native state, or they can be attenuated or genetically changed. Viruses can be bioselected or genetically changed to infect and lyse tumor cells selectively while leaving the normal cells less affected. And they have a dual mechanism of action. They can directly cause the cancer cells to burst by replicating inside of them, but also when the cancer cells burst, they can activate innate and adaptive immune response, which is helpful for generating whole body or systemic immunity. And so at this point, there is one oncolytic virus that's been approved for melanoma that's unresectable and has previously been treated by surgery, which we call TVEC. Its full name is Telimagene laherparec-vec, and this is a cartoon sort of describing the mechanism of action that I just went over. So TVEC is actually a herpes simplex virus. That's the type of virus that's a common cold virus, and it forms cold sores around the lips, and about 50 to 60% of Americans have herpes simplex 1. So it's a common virus in our population. This one has been genetically modified into an agent that's used for cancer. And so the genetic mutations are shown, and this is a cartoon of the string of DNA, and there are a couple of mutations that are made in the genome to make it safer, so it doesn't affect the neurons to the same degree as the natural virus, and also to help it present better to the immune system. So it's been tweaked a little bit, but it's basically very, very similar to the common cold virus that many of us have been exposed to. And this was the phase 3 trial that was led by our own Dr. Kaufman and presented at ASCO meeting a couple years back. And the key number here is that the overall response rate in the TVEC was 26%. This data was all collected between, I think, 2008 and 2012. So most of these patients did not have access to other types of immune therapies unless they participated on another clinical trial. And so TVEC had a 26% response rate, and 16.3% of those were durable, with a very, what we would call, acceptable side effect profile, so not a lot of serious side effects. And so to receive TVEC, a patient has to have a melanoma that's on the skin or just under the skin, because it's delivered by an injection directly into the tumor with a needle. And so melanoma is a prime candidate for that type of delivery because, of course, it's on the skin, and a place that it likes to spread to is on the skin or under the skin in bumps. And so this is an example of a case who had multiple dermal metastases from melanoma that over time, with repeated injections every 2 weeks, the lesion started to flatten, it started to soften, it started to get crusted over, and then after several weeks of therapy, the lesion had completely resolved. And so TVEC is very good at shrinking the injected lesions, but when it comes to looking at the whole body, all the tumors in the person's body, the response rate is low. So this is a laboratory experiment showing that in the bottom row, with increasing doses of virus, and most of the cancer cells are obliterated by the virus replicating inside of it and lysing it. And this is another laboratory study that shows that adding the GM-CSF gene into the virus, which is an immune chemical, helps decrease the size of the tumors that were injected into a mouse model on one side of the mouse, but also the tumors on the other side of the mouse's body that were not injected also shrank down, more so when the TVEC was genetically engineered to carry a GM-CSF chemical signal. And so that's another feature that helps TVEC try to generate a systemic immune response. So TVEC and other viruses have been looked at for what do they do to the tumor. So how does getting an injection into the tumor change the way the tumor looks under the microscope and what proteins are expressed? And so this is data from a Coxsackie virus that we're studying here that shows that 3 patients had research biopsies done before they started treatment with the Coxsackie virus, which is another oncolytic virus, and on day 8 after they were treated. And if you look in the baseline pictures, they're all blue with very little red, but in the second column, the post-treatment samples show that the tumors had increased levels of PD-L1 expression. We've already told you that the PD-1 and PD-L1 pathway is very important in melanoma, and in fact there are 2 FDA-approved agents. And so we have led a clinical trial of the Coxsackie virus in combination with pembrolizumab that we recently reported at the American Association for Cancer Research in a poster format. And the nickname for this study is the CAPRA study. And so if after patients are consented and determined to be eligible for the trial, they get the intralesional or intratumoral injections 3 times between day 1 and day 5, and again on day 8, and then they get combination therapy. And so this is an example of a novel combination for melanoma where the virus is being used to stimulate and prime the tumor, and the IV therapy, the pembrolizumab, is being used to help take the brakes off the immune system to let it generate a robust anti-cancer immune response. And so we reported the results of the first 15 patients. We saw a 60% response rate, or 9 out of 15. And in addition, there were a couple more patients who were stable, and so we called the disease control rate, or the DCR, 87% in the first 15 patients. And this is what we call a waterfall plot, where if the bar goes above the line, that means the tumor grew, and if the bar goes below the line, that means the tumor shrank. So this is a summary. Each patient is a bar, and it's a summary of all the tumors added up. So their overall response to therapy. This includes the tumors that got injected, but also any tumors that they had that were not injected. So if they had tumors in their lungs or liver, they also shrank. So we were pleased with the first analysis of this result. So I'm going to skip this in the interest of time. So for what are future directions of what we hear at Rutgers and what everyone who is in the cancer immunotherapy field, we're focused on novel combinations of usually a backbone of checkpoint inhibitors, since they've been so successful, and combining those with other agents such as co-stimulatory molecules like Dr. Maynard mentioned, or other agents such as viruses, which can help prime the tumor and get a better response. Therapies are no longer just IV, but sometimes they're intratumoral, sometimes they're oral, and that's coming more and more. Also, we'd like to try to develop better biomarkers. We've heard multiple times that that's very important and a lacking piece of the puzzle at this time. And I hope this will help us develop better brain treatments for patients with melanoma brain metastases. And since melanoma is sort of the poster child cancer, or the cancer in which most of the field is turning to for leadership, I hope that we can spread what we know about melanoma to help people with other types of cancer. And these are some examples of studies that we're doing here that we hope to have more results on. And so with that, I'd like to acknowledge our patients, their families, and AIM, and for putting on this event, and all of our sponsors and donors. So thanks very much.